Welcome back to the deep dive. Today we're cutting right to the chase. This is a high-yield revision session.
Exactly. If you've got board exams coming up, FRCS, plastics, max facs, this is for you.
We're hitting two massive topics, frontal sinus and panfacial fractures.
Yeah, these are the ones that can really trip you up in Aviva if you don't have the algorithms down cold. It's high stakes.
So our mission today is to just synthesize everything, the management protocols, the classifications, all of it into one clear guide.
And just before we dive in, a quick flag. We're covering the what and the how right here, but the messy real-world stuff, how you apply this on call at 3 a.m., that's in our premium episodes.
That's right. The Journal Club, the clinical cases.
Mm-hmm.
If you want to hear us break down an actual trauma call, you need that premium subscription. It's the difference between knowing the book and knowing the job.
Okay, let's get into it. Section 1, anatomy and development.
This comes up all the time. A pediatric Viva, they show you an x-ray. So milestones, what are the key ages for the frontal sinus I need to just, have on tap?
You need the whole timeline of pneumatization. So at birth, it's not there. It's basically absent.
Okay.
The whole process, the air cells invading the bone, that kicks off at age 2.
Starts at 2, but it's still tiny, right?
Oh, microscopic.
Yeah.
The next number you need is age 4. At 4, it's about the size of a pea.
Which is why you don't really see these fractures in toddlers.
Exactly. There's just no sinus to fracture. It's solid bone.
Right.
Then radiologically, you start to see it on an x-ray around age 8. But the critical part for the exam is when it finishes growing.
Okay.
And that continues all the way into adolescence. It's usually done between age 15 and 19.
So pneumatization at 2, pea-sized at 4, visible at 8, and done by the late teens. Got it.
Yeah.
Now, the adult sinus, the tables. Can you break down the difference between the anterior and posterior?
Yeah, think of them as having totally different jobs. The anterior table is your shield. It's thick. It gives the forehead its contour. It takes a huge amount of force to break it.
Okay. And the posterior?
The posterior table is a different beast entirely. It's paper thin, and its only job is to separate the dirty, bacteria-filled sinus from the sterile brain.
From the dura.
From the dura and the brain, yeah.
And that leads right to drainage. The nasofrontal duct?
Or frontal recess, yeah, depending on the book.
Right. Where exactly does it run? Because if that gets blocked, that's where the problems start.
It runs from the posteromedial floor of the sinus, so the back inside corner, and it goes down into the middle meatus of the nose. You have to picture that pathway, because if that floor is smashed, the drain is gone.
And a sinus that can't drain is a time bomb.
It is a time bomb, exactly.
Okay, let's move on. Section 2, injury profile. As you said, you don't get this from bumping into a door. What's the mechanism?
It's almost always high-velocity trauma, car crashes, dashboard injuries, major assaults. The energy required is massive.
And there's that set of stats, the rule of percentages that you have to know for boards.
The 20-20-75 rule, you just have to memorize it. First, 20% of these patients are unconscious when they arrive.
Okay, so that flags neurosurgery straight away.
Immediately. The second number is another 20%. 20% will have a CSF leak on presentation.
Meaning the posterior table and the dura are breached.
Yep. And then the 75.
That's the big one.
75% have other fractures. Orbital, nasal, midface. It's almost never an isolated injury. It's part of a panfacial smash.
So if you see a broken forehead, you have to go hunting.
Mandatory. You scan everything else.
Classification. How do we group them?
You keep it simple because the classification tells you what to do. So you classify it by anatomy. Is it the anterior table, the posterior table, or is there nasofrontal duct involvement?
Just those 3?
Well, no.
Yeah.
Then you add what we call impact modifiers. So is there a dural tear? And what's the level of comminution? How shattered is the bone?
And those 2 factors change the whole game.
They shift you from a simple ORAF to a complex, combined neurosurgical case.
Perfect segue. Section 3, management principles. Big picture. A patient comes in, smashed forehead. What are the 3 goals of treatment?
Goal number 1, and this is absolute, create a safe sinus. You have to isolate the brain from the nose, period.
Because if you don't, it's meningitis.
It's meningitis, and the patient dies. That's priority 1. Priority 2 is to restore their facial contour.
The plastic surgery part.
Right, making them look like themselves. And goal 3 is simply to avoid complications.
Which sounds simple, but here it's about avoiding long-term nightmares.
It really is. I mean, early on, you're worried about meningitis, abscess, encephalitis, but the long-term killer is the mucocele.
Explain that. Why is a mucocele so dangerous?
So if you trap any of that sinus lining, the mucosa, inside a closed-off bony space, it just keeps making mucus.
Doesn't know it's trapped.
Exactly. It forms a cyst that just slowly expands, it erodes bone, it can push on the brain, the eye, and this can happen 10, 15 years later.
Wow. Okay, so to prevent the immediate infection risk, what's the antibiotic protocol? The safe board answer.
Baseline is empirical cover for everyone. That sinus is dirty. So 7 days of broad spectrum cover.
And if there's a CSF leak, if you see that clear fluid,
If you have a confirmed CSF leak, most protocols say extend that to 14 days. That's the safe, defensible answer for an exam.
clear. Okay, let's get into the surgical algorithms. Section 4. This is the real meat of it.
Let's do it.
Scenario A, observation. You have a fracture, but you do nothing. When is that okay?
It's a very, very strict set of criteria. We're talking minimally displaced fractures, so less than 2 millimeters.
Okay.
And that applies to an isolated anterior or posterior table fracture. The two big deal breakers are nasofrontal duct involvement and a persistent CSF leak.
If the drain is blocked, you have to operate.
You have to operate. Now, there's a small nuance with CSF leaks. Some places will observe for 5 to 7 days with bed rest.
To see if it seals itself.
Right. But if it persists or the bone is pushed in, you're going to the operating room.
Okay. Scenario B, ORIF, open reduction internal fixation. Who gets this?
This is your displaced anterior table fracture. The key here is the duct is working fine. The posterior table is fine. The brain is safe.
So this is purely a cosmetic problem.
It's a cosmetic operation. You're fixing a big dent in their forehead. You make a coronal incision, you put the puzzle pieces back together, and you hold them with tiny titanium plates.
Straightforward. Now let's get complex. Scenario C, obliteration. This is the one they always ask about. What is it and why do we do it?
Obliteration means you are deleting the sinus. You turn that air-filled space into a solid block of tissue. You do it when the duct is totally destroyed or the fractures are so comminuted you just can't fix the drainage.
If you can't drain it, fill it.
That's the principle. Otherwise, you're guaranteeing a mucocell down the line.
Okay, the books list 5 steps. Can you walk us through them?
Step 1 is exposure. Coronal incision. You literally take the anterior table off like a lid to see the whole sinus.
Okay, lid's off.
Step 2 is the most critical step of the whole thing. Meticulous removal of all the mucosa. Every single cell. You use a diamond burr and polish the bone until it's white.
You can't leave anything behind.
Not a scrap, or it'll come back as a cyst. Step 3, plug the drain. You pack that nasofrontal duct opening with fascia, muscle, something to seal it off from the nose.
Done. Step 4.
Fill the cavity. You obliterate that space with the patient's own tissue. Abdominal fat is the gold standard.
Why fat?
It revascularizes really well and it fills every little nook and cranny. And then step 5 is just reconstruction.
You put the lid back on?
You put the anterior table back on and plate it in place. Now you have a solid forehead.
Perfect. Now for the most extreme scenario. Decranialization. What makes this different from obliteration?
So in obliteration, you still have the posterior table. That back wall is there. In cranialization, the posterior table is so smashed that you just remove it completely.
Is there a cutoff for that? Like a percentage?
The general rule of thumb is if more than 25% of the posterior table is gone or shattered, you cranialize.
And how does that work, technically?
Well, the exposure is the same. But then instead of cleaning the sinus, you separate the dura from the back wall, and you just remove all those bone fragments with the ronger.
So what fills the space? Do you still use fat?
No, and that's the key difference. You don't fill it. You allow the brain itself to expand forward and fill the space where the sinus used to be.
So the sinus becomes part of the cranial fossa.
It literally becomes part of the anterior cranial fossa. And of course, you, or the neurosurgeon, have to get a perfect, watertight repair of any dural tears, often with a pericranial flap for backup.
That's a fantastic summary. ORIF for a dent, obliteration for a black drain, cranialization for a smashed back wall.
If you have that algorithm in your head, you can't go wrong.
Okay, section 5. Let's touch on endoscopy and then panfacial fractures. Is there a less invasive way to deal with a black duct?
There is, sometimes. Frontal sinus endoscopy. A skilled ENT surgeon can go up through the nose and basically drill out the blocked duct from below and stent it open.
Which saves the patient a massive operation.
A huge operation, but, and this is a big, it requires really strict follow-up.
Why?
Because they can scar down and block again. You need CT scans at 6 and 12 weeks to prove it's still draining. If you can't guarantee that follow-up, you obliterate. It's safer.
Makes sense. Okay, last big topic.
Yeah.
Panfacial fractures. The whole face is a mess. There are 2 main philosophies for how you put it all back together.
The great debate. bottom up versus top down.
Let's break those down. What's bottom up?
Bottom up is the classic way. You rebuild from the foundation, you fix the mandible first, get a solid base, then you use that to set the maxilla, and you build your way up the face.
And top down.
Top down starts at the skull. You fix the forehead and the zygomatic arches first to establish the width and projection of the face, and then you hang the rest of the face from that stable frame.
Okay, with the bottom-up approach, there's a golden rule about the mandible if you're going to use it to set the occlusion.
An absolutely critical rule. If the mandible itself is broken, you have to fix it perfectly first, from condyle to condyle.
Why is it so important?
Because you can't use a broken ruler to measure something. If you miss a condyle fracture and you put the patient into fixation, you're building the entire face on a crooked foundation. You'll lock them into a malocclusion.
A disaster. So when you're faced with all these pieces, where do you physically start plating?
You always work from the known to the unknown. You start on the side that's least broken, find the big, recognizable pieces that buttress up against the stable skull. Fix them first.
Don't start in the middle of the mess.
Never. Reestablish the outer frame, then you can fill in the details.
We have covered a huge amount of ground here, from development to the 20-20-75 rule, the surgical algorithms, and now sequencing panfacial repair.
It's a lot, but these are algorithms for a reason. In a major trauma, you don't want to be creative. You want a proven pathway that protects the brain and restores the face.
And I want to leave our listeners with one final thought. That choice between bottom up and top down, it's not just a preference. It's a strategic decision based on the fracture pattern in front of you.
Exactly. If the mandible is dust but the forehead is solid, you go top down. If the skull base is shattered but the jaw is intact, bottom up is your only hope. It's like chess.
You have to see 3 moves ahead.
Yeah.
Absolutely. If you found this useful, please hit that follow button so you don't miss our next deep dive. And if we cleared something up for you, drop us a rating. It really helps other residents find the show.
Yeah. And let us know what you want next. Leave a comment. Is it hand trauma? Flap physiology? Tell us what you're struggling with.
One last time, if you want to hear how all this theory gets applied in the real world on a Friday night, you need the premium subscription. The Journal Club and clinical cases are waiting.
That's where the real learning happens.
Thanks for listening. Good luck with the revision. We'll see you in the next deep dive.